Hello everyone, and welcome to today's webinar. Today's webinar is titled A Model-Based Methodology to Predict the Biomechanical Consequences of Tibial Insert Thickness After Total Knee Arthroplasty. My name is Christopher Iversen, and I work here at Anybody Technology. Today I will be the host of this webinar, and I will be joined by my colleague, Bjørn Keller, who is one of the senior engineers here at Anybody Technology. And Bjørn will join us during the Q&A session and help us out with answering your questions. In today's webcast, we have an external speaker who is PhD candidate Perikles Tzanidis from the University of Twente in the Netherlands. And Perikles is also the founder and leader of the biomedical engineering group Twente. He's going to give his presentation in a minute or so, but just before we start, I will give you a general introduction and overview of the Anybody modeling system, for those of you who are unfamiliar with the software or musculoskeletal modeling in general. So what is the Anybody modeling system? Well, the Anybody modeling system is a software that allows you to do musculoskeletal modeling and simulations. As input, it takes motion data as kinematics and forces, and it calculates internal body loads as joint movements, joint reaction forces, and muscle forces. And down here in the bottom of the screen, you can see a screenshot from the system, which can get you an idea of how the system actually looks. At the moment, Anybody is used in a wide variety of areas and applications. And a few examples of this is movement analysis, product optimization design, the field of sports optimization, orthopedics and rehabilitation, and assistive devices as, for example, exoskeletons. And the typical workflow in Anybody could look something like this. So you provide the recorded motion data as input, and then you use the body models which you or others have built. And then you can provide some kind of environment, which could be, for example, an exoskeleton. You can then use Anybody to combine these things and solve the muscle recruitment and run the inverse dynamics simulations, which basically means that we go from motion to calculate the internal body loads and the interaction with the environment in some cases. You will then get a simulation that looks something like this. We can then go ahead and output the results and use it for some kind of post-processing, which for example could be a finite element tool. But many users also closes this loop completely by doing some kind of design optimization and run this cycle multiple times. I think this brings me to the end of the introduction, and I will hand over the presenter role to Perikles instead.
Well, thanks for the introduction, and thank you all for attending this webcast. I'm Perikles Tzanidis, and I'm a PhD candidate in the biomechanical engineering department at the University of Twente in the Netherlands. Today, I'm here to talk about one of my studies recently published in Applied Sciences Journal that is part of a collaboration between the University of Twente and Stryker and concerns the biomechanical consequences of tibial insert thickness after total knee arthroplasty. At first, I would like to start with some fundamental clinical information about total knee arthroplasty. What is total knee arthroplasty? Well, total knee arthroplasty is a surgical intervention for end-stage knee osteoarthritis, which aims to relieve the postoperative pain and restore the normal function of the knee joint. In total knee arthroplasty, as this figure illustrates, the diseased articulating surfaces of the knee joint are removed and then replaced with artificial components, including a femoral component, a tibial tray together with a tibial insert, as well as a patellar batten, depending, however, on the condition of the underside of the patella. Femoral and tibial components are typically made of cobalt chromium alloy, while the tibial insert and the patellar batten are made of polyethylene. To give you some numbers, according to the Dutch arthroplasty register, about 33,000 primary or revision total knee arthroplasties are performed every year in the Netherlands. And the most common mode of early surgical failure requiring a revision surgery is mechanical instability. Mechanical instability may result from aseptic loosening or polyethylene wear. Let's see an example here. The left radiograph shows a loosening case of the femoral and tibial components in the right knee. And when we say aseptic loosening, we refer to the failure of the prosthesis, often associated with osteolysis. Osteolysis indicates a progressive destruction of the bony tissue and is characterized on a radiograph as progressive radiolucent lines. So if we have a look at the anteroposterior view of this radiograph, we can see that there is a lucency around the medial aspect of the tibial component. If we have a look at the lateral view of the same radiograph, we can see that there is a radiolucent area surrounding the femoral component. Next to that, we can see an example of a polyethylene insert wear appeared in the medial part of the specific insert, which subsequently brings the femoral condyle into contact with the tibial plateau. The thing here is that both failure mechanisms have been associated with the inadequate thickness of the tibial insert. So it's important to select an optimum thickness in the intraoperative procedure to achieve balance in the soft tissue envelope and restore the physiological function in the knee joint, lessening simultaneously the risk of such implant-related complications. Then the question is, what is the optimal thickness? Well, if we have a look at the literature, there is an overall recommendation for a minimum thickness of 6 to 8 millimeters, and then applying the conventional 2 millimeter increments based on the individual case. However, the debate continues about the target thickness with contradictory findings. One of the main limitations of these studies is that the authors actually failed to control for the variability in the depth of tibial resection, which might provide, as you can imagine, an inaccurate estimation of the actual effect of tibial insert thickness variation on the surgical outcomes. But let's think from a biomechanical point of view. If we use a thicker insert than the minimum recommended threshold of 6 to 8 millimeters, and at the same time keep the resection depth unchanged, we can expect to see an increased tension in the soft tissue envelope, right? Which can subsequently result in higher contact forces in the distal femur and tibial insert interface. And this increased contact forces can also be transferred to the fixation site, which can then promote loosening of the prosthesis. So it's crucial to comprehensively evaluate the kinetics after surgery to prevent higher than physiological mechanical stress and strain on the ligament structures, as well as high load levels at the interface between bones and prosthetic components. And since the thickness of the tibial insert can be modified intraoperatively, the surgeon can customize the surgical plan by choosing a thickness that best replicates the natural knee kinematics and kinetics. Musculoskeletal models represent a valuable tool in this intraoperative decision-making procedure. They can be personalized to patient-specific anatomical features and predict in vivo and in a non-invasive way variations in muscle, ligament forces, joint loads, and kinematics due to changes in implant design properties or surgical choices, such as the thickness of the tibial insert. And these predictive capabilities of models can provide quantitative, patient-specific information that can then aid surgeons to formulate an optimal treatment plan tailored to the individual patient. To simulate a model and compute simultaneously all these parameters, including muscle, ligament, and joint contact forces, as well as internal joint displacements, Michael Skipper Anderson and colleagues have proposed a novel technique called force-dependent kinematics, or else abbreviated as FDK. In brief, force-dependent kinematics is an enhanced version of inverse dynamics, which allows small internal rotations, motions in the joint governed by the consequent effect of muscle, ligament, and joint contact forces through a quasi-static force equilibrium. The FDK approach is also exemplified in a work from Mark Kumar and colleagues who developed a musculoskeletal model of total knee replacement, as also illustrated here, with an FDK shoulder that can compute muscle and ligament forces, tibiofemoral contact forces, and secondary knee kinematics. Keep this in mind because we'll talk further about that in the next few slides. Now, considering that earlier studies typically focus on the primary effects of tibial insert thickness on the tibiofemoral joint biomechanics, mainly on the tibiofemoral kinematics, using a knee simulator, the aim of our study was first to investigate the influence of tibial insert thickness in isolation on the tibiofemoral joint in terms of ligament and compressive forces, and secondary to assess to what extent thickness variation affects the biomechanical parameters in the patellofemoral joint. For this purpose, we used the previously mentioned model from Marco Mara, that is a validated musculoskeletal model of a total knee arthroplasty patient built upon the Twentler extremity model template and integrated patient-specific data available from the 5th Grand Challenge competition dataset. For this study, we used the original model and we introduced some changes with respect to the existing patient-specific model using the antibody modeling system. First of all, we configured the model such that it integrates Stryker's triathlon cruciate retaining prosthesis according to the mechanical alignment technique. And we selected this implant as it has shown good functional performance and ligament stability in previous clinical studies. Besides, the patella was not resurfaced in this model, and since the cartilage underside of the patella could not be determined from the patient-specific dataset, we generated an offset of 3 millimeters on the dorsal facet of the patellar bone according to the mean patellar cartilage thickness estimation from the literature. A few more details about the specific model. As you can see, it includes the lower extremity of the implanted side and comprises 12 degrees of freedom in the tibiofemoral and patellofemoral joints. Flexion and extension in the tibiofemoral joint are motion capture driven, while the kinematics of the remaining degrees of freedom are solved quasi-statically using the force-dependent kinematics approach as proposed by Michael Skipper. Again, with this methodology, we are able to concurrently estimate muscle, ligament, and joint contact forces as well as secondary kinematics. In this model, tibial insert thickness was varied with 2 millimeter increments or decrements compared to the reference case that was 9 millimeters, testing 5 thickness cases in total, specifically 5 millimeters, 7 millimeters, 9 millimeters, that was the baseline, and then 11 millimeters and 13 millimeters. And we evaluated the effect of tibial insert thickness by simulating a chair rising activity based on the motion capture data available as part of the open access Grand Challenge competition dataset. After simulating the model, we first evaluated the effects of the tibial insert thickness on the tibiofemoral joint. In this figure, you can see the peak ligament and compressive forces at varying thickness relative to the reference case, that is the gray filled marker. What we observe here is that the thickness variation had a marked effect on the ligament forces, which increased considerably for the medial, lateral, collateral, and posterior cruciate ligaments when using thicker inserts relative to the reference case. At the same time, we investigated the ligamentous individual bundle strain, and we found that both the medial and lateral collateral ligaments appeared to stretch in the same strain rates of about 0 to 6% for all the simulated thickness cases. What is worth noticing here is that thinner inserts, specifically 5 and 7 millimeters, slackened the medial and lateral collateral ligaments almost entirely in flexion. And you can imagine that this is an unfavorable scenario, because slackening the collateral ligaments may destabilize the knee during flexion. On the other hand, and unlike the other two ligaments, the posterior cruciate ligament received more tension in the flexed knee, with tibial insert thickness higher than 9 millimeters, and reached a peak strain of about 10% when using a 13 millimeters component. The question here is whether this percentage is an indication of an overstretched ligament. Well, I would say no, if we consider the yield strain reported in the literature, that is about 14%, above which there might be a ligamentous injury as a result of overstretching. But keep in mind here that this yield strain might be even higher, according to the most recent studies. Similar to the ligament's kinetic behavior, the compressive force in the tibiofemoral joint increased substantially at varying thicknesses, especially with the 13 millimeters polyethylene component. And if we consider that the quadriceps muscle force was roughly the same across the thickness cases, as we will see in the next slide, this increase can be solely attributed to the summation of increased joint ligament forces. Another thing here is that the magnitude of the tibiofemoral compressive force seems to be consistent with earlier observations that report an average peak of about 4 times body weight during rising from a chair without the aid of arms in a natural knee. And of course, this supports our reported values with 9 or 11 millimeters, and at the same time raises the concern that if we use thicker inserts such as 13 millimeters or even more, we could see increased joint loads on the polyethylene surface, leading potentially to destructive wear. Their own surgeons should consider this surgical option relative to the resected bone on the tibial plateau, and bear in mind that a thicker insert also requires a lower level of tibial resection. In addition, a deeper tibial resection may lead to the removal of a considerable part of the tibial attachment of the posterior cruciate ligament, as you can also see in this figure, which indicates a partial detachment of the posterior cruciate ligament. So, to summarize, these findings highlight the importance of a preoperative plan of the appropriate tibial insert thickness, which considers 2 parameters. The first is the thickness value available, and the second, the tibial resection depth. So to conclude, I would say that the selection of a tibial insert that is either too thin or too thick can have a negative impact on the tibiofemoral kinetics, leading to a suboptimal solution. In addition to the tibiofemoral joint, we also assess the secondary effects of tibial insert thickness on the patellofemoral joint biomechanics, including forces and kinematics. Overall, we found only marginal effects on the knee extensor mechanism forces. First, the quadriceps muscle force remained unchanged across tibial insert thickness variations. However, more thickness in the tibial component increased the quadriceps tendon to femur force. And contrary to our expectations, the patellofemoral compressive force showed a slight decrease with 2 and 4 millimeters more polyethylene insert thickness compared to the reference case. And this finding might be explained by a quadriceps femur load serving, as the quadriceps wrap around the distal femur in a flexed knee position. Or in other words, it seems that part of the force is transferred through the quadriceps tendon to the femur as the patella moves distally. This mechanism was also reflected in the patellofemoral kinematics. We found that the patella was consistently more distal with thicker inserts than in the reference case. And that was actually expected, right? Due to the joint line innervation, but this subsequently may result in patellobia. Patellobia is an abnormally low-lying patella. So from a clinical point of view, unloading the patellofemoral joint, as we found in the results of the patellofemoral compressive force, could be beneficial by means of reducing patellar complications after surgery, especially anterior knee pain, which strongly correlates with postoperative patient dissatisfaction and impaired quality of life. On the other hand, patellobia may have serious consequences on the overall function of the knee after surgery, such as limited range of motion because of patellar maltracking. Moreover, a distally displaced patella can impinge on the anterior part of the tibial insert or the tibial tray during flexion, and this can potentially increase wear. Hence, surgeons should carefully assess the concomitant effects on the patellofemoral joint when pre-planning the desired insert thickness to ensure that the patella slides properly in the trochlear groove. At this point, I would like to mention that our study, of course, has several limitations. First of all, the mechanical properties of the ligamentous structures were defined from the literature, although may vary for each individual. Second, this musculoskeletal simulation represents only mechanically aligned, cruciate-retaining total knee arthroplasty, meaning that the results cannot be extrapolated to other surgical techniques or implant designs. And to connect with the previous 2 points, this computational model simulated only one patient, while there is anatomical variability or even other pathological conditions among different patients. Then what's next? Well, in terms of future directions, I would like to mention that we're currently working together with Stryker towards the implementation of personalized surgical planning, which aims to restore the knee function to the pre-diseased level. And to achieve this, we use patient-specific musculoskeletal modeling in combination with advanced medical imaging and surgical robotics to define and execute an optimal surgical plan customized to the patient's characteristics and needs. Besides, we are conducting research on the biomechanical effects of morphological knee joint phenotypes after total knee arthroplasty. And to do this, we combine statistical state models and musculoskeletal modeling and simulations. Before closing, I would like to acknowledge the important contribution of my colleagues at the University of Twente in this work, and also thank Stryker for providing the geometry files of the prosthesis used in this slide. I would like to thank you for your attention, and of course, if you have any questions, please feel free to ask me now using the chat feature or contact me by email.
Thank you very much for a great presentation, Frederick. Yeah, so I would just like to say a few words regarding our online resources. So if you want to know more about Anybody Technology, you can go and check out our website, anybodytech.com, for events and special dates, and also a full publication list of studies featuring the Anybody modeling system. You can also go and check out anyscript.org, which is our community website for people using Anybody. And here you can find multiple online resources as our wiki page, several blog posts, and links to our repository sites. And it's also here our forum is located, so you can go here and ask questions and get help from some fellow Anybody users. I would also like to point your attention to an upcoming webcast we have on June 3rd, and this will be a joint webcast together with Exons, where we'll have invited a couple of speakers to present how they have combined motion recordings with the Exons system and analyzed the motions with Anybody modeling system. And we do also have an Anybody workshop coming up during the technical group of computer simulation on July 21st. And this event will be fully virtual, and there will be open for registrations very soon. But I'll try to update our event page on the website, and you can also keep an eye out on our social media sites where we will post this when the registration opens. And last but not least, if you have any questions or you want to meet up or you are interested in a trial version of the software, then please feel free to send us an email at sales@anybodytech.com. And if you have any follow-up questions after this webcast, then please feel free to send me an email as well at ki@anybodytech.com.